And welcome to everybody who's joined us on this chilly November evening, and thank you very much for joining. This is part of a wider series of events looking at the nursing voice through the COVID-19 pandemic, and obviously organised by the Royal College of Nursing Library and Events team. So in this event, we are looking at the nursing role in the COVID-19 vaccine delivery and rollout. So I'm really delighted to be able to introduce this talk, and I should have introduced myself at the beginning. I'm Helen Donovan. I'm the professional lead for public health nursing here at the Royal College of Nursing, and have been leading the vaccine content and delivery and as much as I can from a clinical perspective, and also have been vaccinating in a variety of centres. So really delighted to be able to do this. I also want to introduce my colleague Heather Randle, who is also here from the professional leads team. So Heather is the professional lead for primary care nursing. We have two interviewees. We have Carole Phillips, who I'm delighted to welcome. Carole is the clinical director for the Brunel Healthcare Primary Care Network and has been involved. Carole and I think we met each other early, about over a year ago, when the planning started. So really welcome to you, Carole. And we've got Louise Cahill, who is clinical coordinator for the COVID-19 Vaccination Centre in Newport in Wales. Lou and I have known each other for many years, and I'm sure lots of RCM members will know Lou. So really delighted to have you both here. We were hoping to have a third interviewee, May Parsons, who probably needs no introduction as being the first person to administer a COVID-19 vaccine outside the clinical trials, but she's been on leave, and unfortunately she's not able to join us. So without further ado, I'm going to start this by starting to talk to Carole. Carole, what was your first sort of memory of COVID, and do you remember where you were and what you were doing when you first sort of thought COVID and a pandemic?
Yeah, I've been a clinical director, so it's I'm really, really fortunate, Helen, as you know, to be one of 16 nursing clinical directors within the primary care networks, and part of that role is to work at STP and NHS England, and also regional and local level. So we had started having joint calls with the hospital because of the demand that was going up in the hospital, and they weren't just normal coughs and colds. These people were coming in seriously ill, and we didn't know what was going on, and it really took us by surprise. And A&E was at 6-7 hour waits. The same day access was full, everywhere was full, and we were primary care were overloaded as everyone else was. And at that time, I mean, that was late December, early January. We were all shocked at the speed of all of this, and we had to set up a working group with the hospital hub fairly quickly to help with their workforce. The workforce, they didn't have enough workforce, they didn't have enough people to deal with the people that were coming. So as a collective in Portsmouth, we're very lucky. It's a city, a fairly compact city centre, and we worked together as a team, city and regionally, to work out what was going on, and we worked with Public Health England. Once we started realising that this was a serious pandemic, it took us all by surprise, and it was quite scary at the time, I think. And we set up our COVID hub. We were one of the first in the city to set up a red hub when the COVID struck.
And I mean, sort of we're nearly 2 years, aren't we, from when those first cases. Similarly, I remember those times and sort of starting to see the cases and thinking, this is really going to develop into something, and being told I was Mrs. Doom and Gloom, but you could see it, couldn't you? Really?
Yeah, you could. Yeah, and our colleagues, all our colleagues, those that are in the RCN and those that are in the Unison, we on WhatsApp wasn't quite as prolific then, but we were all saying, what's going on? Are you seeing these cases? people seeing these cases, nurses were coming down with it, healthcare were coming down with it. So, you know, from that, I mean, with the last 2 years have just been a blur, really, haven't they? So we started with the red hubs, and then about this time last year we started talking, didn't we, with NHS England about what we're going to do, how we're going to manage this, and setting up. They were talking about mass vaccines and roving sites at the time. They weren't talking about local vaccination sites, were they, when we started?
Well, that was going to be my next question, was sort of like, you know, so we had the cases and the sort of management of the sort of clinical disease, but then sort of becoming aware that a vaccine was going to be coming, and hopefully imminently, and what were your memories of that time, at that sort of early, sort of before the vaccine rollout, but you know, the planning bit?
I don't know if you remember those funny names that they had them. Remember when? So we were part of the planning group for mass vaccine site. What would they need? You know, what syringes? Down to that, wasn't it? Syringes, gauzes, needles, stuff like that. And you know, the thought of vaccinating on mass vaccine sites, and how we were going to do that, the logistics of doing that with that team of, I mean, there was probably 10 of us sat around on MS Teams, weren't we, going, oh, well, we'll need this and we'll need that and we'll need the other, you know, and thinking up in practice, what colour bins do we need? Do we need all those colour bins? Because we didn't know what the vaccines were. We didn't know if they were toxic or anything. So do we need the orange bins? Do we need the purple bins? What do we need? So those conversations well into, you know, 16, 17 hours after a shift of COVID, you know, the COVID oximetry at home as well. We were doing that as well, weren't we? So it was all around that time when we were trying to work out, you know, left from right, really. And
I think, you know, you alluded to it there, but, you know, this sort of like development, mass vaccination site, and we'll probably come to that when we talk to Lou, but, you know, this feeling that there needed to be other delivery models as well. And obviously you've been very instrumental in the local delivery, the primary care network delivery. So what was your sort of memory of that, and how that developed, really?
Well, I think that developed because we, as a city and as a region, the mass vaccine site wouldn't get everybody, all those vulnerable people, you know, the housebound people, those people that just couldn't get to those sites. And I think one of the first thoughts, you know, that the mass vaccine sites would be predominantly in the city centre, but that, you know, they were saying, oh, well, Southampton could have one and Brighton could have one, and we're like, well, what about the people in Portsmouth? And we know our patients better, you know, as the people who are on the call today, they'll know their own patients. We give flu vaccines, as you know, we give flu vaccines every year. We have that public health programme anyway. So we pushed very hard that really the majority of time, a lot of the vaccines we could give, because we knew our patients, we know our patients, we know who are vulnerable, we know who are housebound. The majority of the well could go to mass vaccine site, but we were worried those people, those vulnerable people, the people that are housebound, those people that couldn't travel very far, that they couldn't get to the mass vaccine sites. And we pushed very hard, and I pushed very hard, as you know, Helen, pushed very, very hard for this to be done at general practice level. Because of that reason, we needed to make sure that we got to the most vulnerable people, and those most vulnerable could not get to mass vaccine sites. And then they thought about the roving. Oh, the roving will get those people. We'll do some mass roving. And then the logistics around, you know, when we heard about the Pfizer vaccine, because that was the first one we heard of, and the defrosting and all of that business, and you know, how would you do that in a roving van? And you know, there's 6, you couldn't move it, and you have to wait 15 minutes afterwards. The logistics was a nightmare. So I think what we ended up with in the local vaccination centres was partly because I think I was nagging a lot, to be honest, Helen. I think, if I'm truly honest, it was just, no, we can't, you know, we can do this at GP level. We can't just have a mass vaccine and roving. We need to have something else. And I think in the end, you know, being listened to, there wasn't just me, it was a fast moving programme, wasn't it? And more people got on board. And I think when Jonathan Leach got on board, I think he really understood it then, didn't he? As the medical director of the vaccine programme. So once he was on board, it was very clear that we could deliver, not the majority of it, but a vast amount of it. I was just before we came on, I was trying to look, there's a GP dashboard. So I was just trying to look at how many we've actually done in the local vaccination sites. So when Lou's on, what I'll do is I'll go on and have a look, and then I can post it in the chat so people know. But I'm sure the people who were on the call, they've all been involved in the vaccination sites, as you have, around the cities, giving the vaccines. I think in terms of GP land, I think we didn't think it was going to go on this long. We really didn't think that we would be here, 12 months down the line, still looking for people to vaccinate. But and I think we as nurses, and not just me in the local vaccination centres, Louise will tell you, everyone stepped forward and came forward at the beginning. When we got those first vaccines in December, can you remember getting those, Helen? I'm sure that the people on the call will remember getting those pizza boxes and thinking that they're like Fabergé eggs. They were so delicate and so tiny, and they just meant the world to us, didn't they? And
absolutely, yeah. And I think so my recollection, as you know, I've been sort of vaccinating in different sites, so the accessibility questions and making sure that we had lots of different opportunities. And obviously that's sort of a challenge now, because the program's still going on with the booster program, but having hospital hubs, but the roving sites, but also delivery to the more vulnerable groups, so how homeless people and sort of what we sort of tend to call in public health terms the underserved communities. I don't like the term hidden, because they're not hidden, they just not. We don't plan services with those in mind. But you were saying about some of the very vulnerable groups just before we started, and those calls now that you're making. So do you want to sort of like talk about that and the importance of that?
Yeah. So we in Portsmouth, we've got a very diverse community, and we decided that as PCNs, there's 5 PCNs in Portsmouth, so we split the care homes down between the 5 PCNs, so that the care homes would be covered that way. And then the BAME community, we opened mosque, we had vaccination clinics in mosques. And what we did for the homeless and those that weren't, the asylum seekers and people like that, we went down to soup kitchens and to day centres and to shelters, went to the port, to Portsmouth Port. So we went down there to get them vaccinated, and they were very, very keen and willing to have the vaccine. Actually, we're going out to do the boosters and the flus this next week. But there are still a lot of vulnerable people that now I'm getting down to the nitty gritty. So today I've rung a 17-year-old who's pregnant, who was really scared of having the vaccine, really scared being pregnant, trying to engage with a midwife to try and get, we've got quite a lot of pregnant and breastfeeding ladies in the city that aren't getting the vaccine. So we're trying to get the message out there to them that it's safe, and get engagement from the midwifery and the gynae team. So it's getting down to the nitty gritty down. There's 64 pregnant women in my PCN that I need to have that individual conversation with now. We've got 300 immunosuppressed patients that have to have a third vaccine, that they don't know they have to have a third vaccine. So we've got to have somebody to have those calls. So now we've done the mass vaccine side, we've done the general population. Now we've got to get to those really extremely vulnerable people, and that's our challenge now, is to make sure that those people who have got vaccine hesitancy, they get the right information at the right time, and know that if they decline now, it doesn't matter. You have a think about it. You have a think about what's going on in your life. And if you want to come back and have the vaccine between now and March, we've got an evergreen offer. You can come anytime. And having those, having walk-in clinics, having booked clinics, changing the days that you put on the vaccine clinic. So we did a Sunday morning clinic a couple of weeks ago, because, well, it was when the churches went back fully. So that's probably a couple of months ago now. But we did after the surgery, the church, whatever they call it. Sorry, I don't go to church. But we had a service. That's the word I'm looking for. We had a coffee and vaccine, coffee, cake and vaccine. So, some of those elderly people that finally got out to church, who didn't want to come to the surgery, we did it for them there. So it's that innovative way of giving, you know, we've got the governance, we've got the assurance, we've got the national protocol. So we can, as long as we can assure that we've got trained people, we've got the, you know, we've got the governance right, we can get these hard to reach groups. And I'm sure there's lots of nurses out there who have got people in their cohorts, in their GP practices, that don't want to go to the vaccine sites at all. So we can, if you've got a special group of people that you can't reach, we can actually move some of the vaccines now to the practices. So, and if we can do that, and we can do that safely, then we can get more and more of these people that are vaccine hesitant for whatever reason to come and have the vaccine.
And I think that's so important, isn't it? It's about looking at those local we say it all the time with public health, don't we? What's your local population? What do we need to put in place? And I guess that's one of the good things that we've been able to do, is to be able to develop services. And, you know, some of the stories that you hear, you know, going into, as you say, mosques and other religious buildings, but also into other community centres and having sort of mobile clinics, mobile vans and stuff. But I guess my next question would be, looking back, what would you do differently, or what would you try and do differently?
What a big question. Oh, so I think probably one of the things, I would change is probably not to take so much on myself. I think we all, at the time, we were all so overwhelmed with it, and just generally making sure more people were clinical leads. So for me, my PCN is 55k population. I've got 2 clinical nurses that follow me, but I didn't at the beginning, it was just me. So I was doing it all. So it took me a while to think, you know, it took me a couple of months really to think I need some help here. I'm not just the only person in this. GPs, as you know, GPs were giving their time and being clinical leads, but once we had to go back into general practice, it's difficult for them to do the clinical lead for the clinics. So I you know, advertising and taking on as a PCN, taking on clinical leads for the vaccine, I probably wish I'd done that sooner, to be honest.
And I think that's sort of like a lesson. I mean, it's quite a nursing way of doing it. Oh yeah, we'll get in there, all hands to the pump, we'll make sure that this happens. But it's that sustainability, as you say. You know, we're nearly a year on now and we're still vaccinating, and we've got to carry on, because obviously the third dose and the booster doses for certain groups, but it's those hesitant population who we still need to sort of do all of those interventions, and that's quite time consuming actually, isn't it?
Yeah,
it might be relatively small numbers in terms of the sort of graphs and everything, but they're so important, and hopefully that then spills out into their community once you start getting those messages. So I guess you know, we've discussed this, but in terms of this program, but what do you think the lessons are for bringing it into the wider vaccine program, or if there are future mass vaccine programs? Any further reflections on that?
I do think bringing the wider community, the nursing community in particular, I think we did well in general practice to get our voice across, because there are some really good voices in general practice. But one of the areas that I think we probably missed out on and we should have got was, you know, the travel vaccine nurses, the community district nurses. You know, they still, I don't know about anywhere else, but in our area, and the care home nurses as well, they are people that could vaccinate, and they could, you know, very easily be trained and vaccinated. And we still haven't really collaborated with that group of very highly qualified professionals that could help us on this journey. You know, particularly, you know, the care homes, the travel vaccine. You know, we are allowed to employ people under NHSP that are immunisers, because they've gone to an HSP and got trained. But we've got trained vaccinators out there. The travel health vaccine, you know that, Helen, you know, we've got those people. And I think that's one of my biggest regrets, is not getting that community of practitioners to help me out with the vaccine clinics. I think
And
that,
it's sort of been quite hit and miss, that, hasn't it? I mean, certainly Heather might reflect back on this, but some of the queries and comments we've had from members is, I'm a vaccinator, how do I get into help? And it does seem to be quite variable, shall I say?
yeah.
And, some of the sort of, how do you get into that program? How do you demonstrate? I mean, obviously, demonstrating your skills and competence is absolutely vital, but there are maybe other things that we could have done for that ready workforce, as you say, the care home staff who've been delivering flu vaccines and the travel vaccines and other programs. I mean, even I have had problems, I have been able to get in, but I have had problems getting through some of that governance. And I just, that's a reflection for me. So I think, for bringing it into the wider program, that's something that we probably could do with some thinking through in the future.
Yeah, we got GPs to vaccinate, and we got medical students to vaccinate. We got physicians associates. But there was, I don't know, Lou might be able to help me, but we even had some ODPs that wanted to come and vaccinate, which would have been great. But they're needed in the hospital, so you didn't want to take them away. But we could have done better, and that's my biggest regret. I think if there's any more mass vaccine campaigns, I think we really need to get those people, the travel vaccine people, in. Our practice nurses have been brilliant. They've all done their share. I've got school nurses that have done, that have had to go back to the school nurses now. I've really relied on a lot of our retired nurses actually to come back and help me in the vaccine clinic. And having army connections is good, because I've got a couple of army nurses as well, so that's been a bit good for me as well.
We found it was quite a challenge, Helen, didn't we, from our point of view, because we're not in that clinical environment so much, getting in to be vaccinators, wealth of experience, but actually it was a real struggle, wasn't it, to get into those environments. So I think that would be something good to pick up.
No, definitely. I mean, I think we're coming to the end of my questions for you, Carole, but I just wanted to just give you the opportunity, if there's anything else that you wanted to say and reflect on before I pass over on to Heather and to Lou.
No, just really to say thank you to all the practice nurses out there that have done a fabulous job at vaccinating their own patients and helping out with the vaccine clinic. And anyone that has got any concerns about, taking people to the vaccine clinics or asking people to come to your vaccine clinics, I'm more than happy to take offline and help you with the assurance to get those people vaccinated, really.
Okay, that's brilliant. Sorry, I lost you for a minute. I think it's my internet connection. So I'm going to thank you so much, Carole, and thank you for joining us. And obviously, hopefully you're going to stay for the questions at the end. So I'm going to pass over on to Heather now, who's going to take over, and Lou.
Hello, everyone. That was a really interesting discussion. So thank you, Carole and Helen. So now I've got Lou Cahill, and she is from Wales. Am I right?
Yeah.
And she's been a clinical coordinator in the COVID vaccination centres in Newport. So she comes with a wealth of experience. So welcome, and thank you for your time tonight.
Thank you for having me.
That's okay. So we've got a few questions, probably along the same lines. Just to sort of recap. So do you remember what your first memory of the of COVID was? Do you remember the first sort of conversation you had around COVID?
So in the summer, so I do a lot of work around crime and different things, and in the summer of 2019 I was offered a scholarship to do a master's at the Jill Dando Institute for Crime Science at University College London. And I looked ahead and thought, when you look at 2019, September to June 2020, it's looking really quiet. There's nothing going on. I've got no training. Things are pretty standard, pretty boring. I thought, I'm gonna go for it. When do you ever get offered that kind of opportunity? I'm gonna go for it. I'm gonna leave my job. I was looking in the emergency department at North Bristol Trust, and I thought, I'm gonna take that time and go do it. So I sort of stepped away from health, thinking that it was all going to be great. So maybe it was daring to do that caused this whole pandemic. I was in I remember the last 2 weeks before my program, my physical lectures finished in March, I didn't travel to London. So I remember seeing it on the news. I remember seeing how other countries are responding and how we weren't responding in that way, and thinking, getting on a train, going up to London and then the tube and then to classes, and I'd be staying with friends, and it didn't feel the right thing to do. So I didn't travel for those 2 weeks. And then the lockdown came, and then the phone call, please come back, came in. And then at that point, I took a role with Aneurin Bevan in Wales, because they offer something called a primary care academy, where they take experienced nurses from all sorts of fields and basically train them up in everything primary care and primary care management. So I ended up going into that and sort of facing this from the primary care level. So
thank you. And did you ever expect it to be what it became?
I think so. My mum is obsessed with pandemics. We even brought her a board game called Pandemic many years ago, and she, as soon as it started, she was convinced, and we were all saying, oh, this is only because you love this kind of stuff. But I'm not sure. I think it was very hard to tell at the beginning whether this is going to be something that would be a bit like swine flu, where it was big in some places and not in others. I was living in Canada during swine flu, and it was something that it just wasn't really a thing. We were told, wash your hands more, but that was kind of it. Whereas my sister was living in London in the UK, and it was a really big deal, work from home if you can. And so there was different approaches at the time. So I wondered if it'd be something a bit like that, but I didn't expect it to be quite as big as it got.
Don't know if any of us did, but yeah, thank you. So when did you first start to hear about vaccine development, and did you think that vaccines would be available as quickly as they were?
So it was really good. I'd been following vaccines a lot, looking at who was working on what, and the BBC had that great chart that you could follow that constantly moved around and showed you the stages that all the different manufacturers and countries and research bodies were at. So I'd been following that for a while, so I knew that they were coming and had reached a point where they were kind of imminent. We, in end of October 2020, we were called in to a meeting. So we do 4 days in practice and a day in study for our primary care academy. And one of the heads of primary care came to talk to us and said, we think we're going to need you to come and help organise and run our vaccine centres. We know that that's not exactly what you are expecting, but we think it'd be a great experience for you. And we were all up for it. So it was no converting us. We all thought it was brilliant. But we're slightly different in Wales. So we have health boards, which I don't know if people are aware of. We don't have trusts and then CCGs and then primary care networks. We have health boards which link up everything. So our vaccine campaign was run by primary care, and that included mass vaccination centres, GP centres, homeless organisations, care homes, your district nursing teams for those at home. So we had that really linked in service. So we were. So
your vaccine clinics were led by primary care.
Yep. So it was led by our primary care director, plus our director of primary care public health, and then we had an ops manager who is also a nurse. Her name's Wendy Warren. You will all know Wendy Warren because she is the person who made Boris Johnson clean chairs when he came to our vaccine centre. So you've probably all seen the memes narrated by David Attenborough and all the rest of it. But that was Wendy Warren, who is our ops manager, and then we have an emergency planning lead nurse who was also put in charge. She was sort of our senior person to go to.
So when you first started to develop these, what was it? Was it clear at the beginning what your role would be, and what exactly was your role when you started out with it?
Not really. They'd had a little look at what the sort of clinical leads did for the testing centres, and had sort of tried to sort of match a job description to that. Thinking, well, it will be something kind of like that. It turned out to be nothing like that. So we had a really great support network. Like, our program board was so open to everything and really open with communication, what we were working on, what we knew, what we didn't know. They were very candid about that sort of stuff. And, you could call anybody and ask any questions. So it was very much one of the, somebody once said to me, it's going to be like building a plane after it's taken off. So I thought that was a really good analogy of what we were doing. You know, we had the sort of bones to take off, but we didn't really know exactly what else we needed and how it was going to work. So it's constant change on the ground as to what we were doing. You know, we were doing anything from, we started out with one centre in Cabran, and then by the January I was putting stickies on the floor at the Newport Centre and trying to figure out where to put barriers and where to line our queues up, because of course January and the weather's terrible, and then at the same time recruit your vaccinators and things.
So that kind of leads on to then, so what role did you play in the vaccination clinics? I mean, I presume you're still involved with them now, are you?
So the clinical coordinator role became sort of the lead clinician on site. So you had overall responsibility for the site. On each site, we had a pharmacy section. So our primary care pharmacists came and they would sort of mix up and prepare our vaccines for us. And we had our vaccines immunisers, who were a range of professions. So a lot of people redeployed. We had a lot of students that wanted to come and be involved as well. All sorts of people from different professions, nurses from all sorts of different areas. And then we had an administrative team that were led by an administrative lead that came sort of under the clinical controller, and they managed all our checking in process and our administrative process, making sure we got the right leaflets and the right information as they were coming through. So you were responsible for making sure there was enough vaccine, everything was safe. A lot of questions. You would, at the beginning, you would talk to so many people, and then when things changed, you know, particularly around AstraZeneca and the issues that it had, we were having such conversations with so many people who would ask questions to the vaccinator and say, oh, I'm really not sure, I want to talk to somebody else. So you would be called over to answer a lot of those questions.
And how is the vaccination centre now? Has it changed from when you first started out? I suppose, what things have you learnt that mean that your vaccination centre runs more smoothly now?
So I have just recently left full time, so I'm still helping out ad hoc, but I've recently been returned to my programme. I was supported to run some research projects throughout, looking at things like queue times, wait times, expectations of patients, the types of questions we were getting, the types of problems people felt they were having, and would put those into reports and return those to the programme board so we could make adjustments and move forward things. Because of the way our health board was structured, we were able to tie in to everybody. So we started off, we got quite criticised, Wales, at the very beginning. You know, they're so slow, off the mark. If you remember, we were getting slammed in the media. But behind the scenes, we were saying, this is going to be big. We've never done something where we have to vaccinate everybody. Let's do it right. So first of all, we built an IT system called the Welsh Immunisation System. It meant that every vaccinator had a laptop and could access this system. This system drew from GPs' systems and also returned to GP systems, so GPs knew who had been vaccinated and what they'd been vaccinated with and when. So it was a two-way system, which was brilliant, and still to this day is fantastically useful. It also meant that we were able to access everybody. So we had a system where the health board invited everybody in order and in groups, but everybody got an invitation. Everybody got 3 invitations in the post to attend, so you didn't have to call up, you didn't have to try and make an appointment. Once it was your group being vaccinated, you got a letter in the mail. Your appointment is Thursday, 12 o'clock. We normally gave people about 2 weeks notice in advance. After 3 no-shows, Wales put in a programme called No One Left Behind. So we would then try and understand why you hadn't attended. We had public health teams that would call people and say, we've noticed you haven't shown up for your appointment. Is there anything you'd like to talk about? And helping people to access. Sometimes people would say, I work these hours and I just can't get there until a certain time. And in which case we would make them an appointment at a time that worked for them. And others had a lot of questions and they were then supported to answer those questions. We had a GP that was available all day, every day that we were vaccinating, and they covered the different regions within our health board. So we have something called NCN leads, which is our neighbourhood community networks. And those GPs sort of led for each of their networks and would be available to answer questions and could also access them patient records. So if we had any questions about anything and we weren't sure. And then we worked with our homeless organisation. So going out at sort of 5 a.m. with bacon butties to our tented communities and doing vaccinations then and offering them to people, because we knew 5 o'clock in the morning, they'd be there in their tents. So that was an opportunity to get them. And then we had a lot of things like walk-in policies. So we didn't normally do walk-ins, but no walk-in was allowed to be refused without going through the clinical controller. So that meant that the admin team would come up and say, oh, there's somebody that's just walked in. Sometimes it's somebody that just didn't know they needed to make an appointment or wait for their grouping, you know, maybe they were too young at the time. And sometimes it would be somebody who was perhaps in an undocumented migrant group, so they weren't on our system. So we had a separate location where we would keep their information, we would vaccinate them and give them a date to return, and so we would make sure we'd capture their second. And it was a way of assuring them that their information wasn't going to be shared with anybody. And then there were other vulnerable groups, so homeless groups and things that would just show up looking for vaccinations, and we would never turn them away because fine, they didn't have a booked appointment, but what is the chance this person is going to return?
Seize the opportunity while you're there. Yeah. So you've mentioned your homeless and asylum seeker kind of groups. What about other groups like your frail elderly, for example, or people from ethnic minority groups? How did you make sure that they were included?
So the GPs recognised that there would be individuals that wouldn't be able to get to mass vaccination sites, even though we had transport and all sorts of things arranged for them. So once AstraZeneca came online, that was given. So we didn't do Pfizer in GP practices in Wales or in care homes. So at the very beginning with the care homes, we had a district nursing team set up that identified all of the care homes, all of the patients, everything was set up, who was going on what day. And as soon as AstraZeneca was online, that was all done in a matter of weeks. So we did our care homes so quickly. And with our groups, so as we came through like our P10s and our people in our 80s and then these different vulnerable groups, they could go to the GP practice. So they would be, certain groups would be invited to the GP practice as opposed to the mass vaccination centre. And so things like with our immunosuppressed groups, the GPs would run a list and provide that to the health board, who would then invite those individuals for their third vaccine, so they weren't ever left behind.
That's really good. I know I have a house in Wales, so I know that in the local village, they had it in their community centre as well. So you did some community centre vaccinating as well, didn't you?
Yeah.
Just invite the village, I presume, was that?
Yeah. So we would show up places that we knew we were having low turnout in this area. Because we had the Welsh information system. It meant we could look at data and you could map that data and say, oh, it's a little bit low in that area. We need to focus on that. So before it became a big problem, you were able to get in there and do something about it. Often it would be low socioeconomic groups that just couldn't travel and they didn't fall into the GP groups. So you would go in and you do what we call pop-ups. So you would give people lots of notice in 2 weeks' time, and we'd often try and make it things like Saturdays or Sundays, so people weren't in work and would go to those areas and do it. We also had one vaccine bus that we didn't really use it very often because we tended to use pop-ups more. But we did have a vaccine bus that we could take around to certain areas and do certain groups. We also, one of our public health leads, also a nurse, her name was Randle Hobbs, and she had a real thing about making sure that we didn't lose groups in this and that people weren't forgotten. So she developed videos for traveller communities and things about vaccine trust and vaccine hesitancy, and she got nurses and midwives and different people to talk on it, and then she would arrange trips to our travelling communities and help to vaccinate them in their own environment. So it was really good.
Yeah, sounds really good. So thinking about sort of how you think maybe things could have been done differently, if you could, go back to the beginning and what were the key things you think you might do differently, or you would recommend that your board did differently?
I think I was really impressed with our health inclusion. I think one of the things we should change is the way we communicated to pregnant women not to have the vaccine. It's something we're actually seeing now with individuals. It's something we're actually seeing now with individuals who are in groups getting boosters, who were originally told at the very beginning that they couldn't have Pfizer. And what we said was, no, you can't ever have this. It's not, your guidance says you can't have this. When actually we should have changed our phraseology. At this time, it's not being recommended. Research is ongoing, that may change, because now people are a lot more nervous about, but you said no. Yeah. You said no, like you were emphatic with your no. So it was something that we were really cautious cautious of now that we're fighting a battle against it, when I think had we changed our language at the beginning, we wouldn't be.
Oh, Helen's got a hand up.
I think that's really important, isn't it? And you said right at the beginning, you were talking about the constant change of the programme, and it's a reflection of mine, I think, that we need to do better, because vaccine programmes always change. I mean, this one has been sort of like at such a pace and such a speed.
Yeah.
But actually, when you look, I've just been doing some slides today on HPV vaccine, and when you think of the way the programme has changed over the 12, 13 years that we've been running it, it's inevitable. And I think you're absolutely right. Those messages, at the moment, we are recommending, as opposed to this is not. And I think in terms of keeping vaccine confidence, that's really, really important, because I would echo that as well. So I think, from a lessons learned for me, I think it's that message through, vaccine programs change because you do develop understanding about not just the vaccine, but also how you approach different things.
It's not like we don't have history on that, isn't it? Because we know that vaccines evolve. We know that the frequency of vaccines change. We know that the groups of people that we're going to vaccinate, HPV, for example, is going to change as we gain more data and more evidence, don't we? Carole, I can see your hands up.
It was just to say that we gave that information because that's what we were told to give, wasn't it, Lou? That's
Definitely.
It was the information at the time, and we did actually vaccinate some pregnant women at the time because they were very vulnerable, worked in vulnerable situations.
Yeah.
And there was a question in the box about learning disability groups. I don't know about you, Lou, but we ran separate clinics for people who had learning disabilities, and we still do, and we are still catching up with those people because they are still scared. I mean, I had one boy who all he ever wanted to do was to go on the 700, the bus 700, and he had a really bad autism, and he wanted to get back on the bus, and he couldn't because the bus couldn't take him because he wasn't vaccinated. So we went to his house. He wasn't housebound, but we decided, because of his autism and because he was really, really vulnerable and he wanted to get back to traveling on the 700, that we would do that for him. Now, the health board in Wales sounds amazing, but it sounds a little bit like our CCG. So we did it at CCG level rather than we did the health board. But the messages that we gave to the people, and maybe that's one of the things that we need to think about, is the messaging that we gave at the beginning. We gave the messages that we were given, at the time. And I think one of the things we probably need to get out there, and the team that's on the call with us will help us. AstraZeneca, you can have a booster of AstraZeneca now. So, just this week, that's come out this week. So those people that were scared of Pfizer and didn't want Pfizer because we'd said they couldn't have Pfizer, well, actually, you can have an AstraZeneca. There is AstraZeneca out there, and we can get it and we can give it. So that might be the next message that we need to send to these, the pregnant women. I mean, the one I spoke to today, I offered her AstraZeneca and she was fine with that. So, it is the messages, and we have to maybe think about those differently. Yeah.
I think
it's something I do in all of when I talk about vaccines now in primary care, it's actually something that I'm mindful of now, and it's changed my practice in a way towards all the vaccines that I give. I talk about what we know now and try and phrase it in a way that if it changed, that person their expectations would be managed to think, well, that's not unexpected.
And it's not that it's more that we didn't know, not that we didn't trust. And I think that's a really important message.
I think that's something that we knew that from previous vaccine programs, and we didn't take that learning through. So in terms of sort of lessons learned, we need to think what we do well. I mean, interestingly, one of the things as well, I think you mentioned IT systems, and I think you're absolutely right. And Carole, I saw put, having data flow from the COVID vaccine program or any vaccine program back to the GP system is so vital. I mean, and I think I've been having this discussion for 20 years now. But one of the things that struck me, and I've had it raised to me by several people and I don't know whether it might be different on the Wales system, but on our Pinnacle system that we're using in England, there is a question about, have you had a vaccine in the last 7 days? And of course, that doesn't apply apart from for shingles vaccine. But people ask the question, and it makes people think, well, and I've had friends and family say, well, I had the flu vaccine, does it matter? And I go, no, it doesn't. You could have it, you know. And even to the point where somebody said, well, would it be all right if I had it on the same day, but there was a 7-day gap? No, you know. And I think because the question is there, particularly people, and I suppose it goes back to what you were saying, Carole, about getting people who are vaccinated, vaccinators more, people who are sort of just bought in and trained to do the programme, go through, understandably, the checklist, but, you know, without maybe having that sort of wider understanding and the inevitability that the programme will change. So I think it's a really, we've sort of like, did you want to finish off, Heather? I realised that we've sort of
I was just going to say, and maybe to both, well, to all of you, now that we're moving into the vaccination of children, my younger children are not old enough to have it yet. I can't wait for them to be vaccinated. But I wonder how our messaging is needs to change, because we were excluding children, same as we were excluding pregnant women. And I think on Pinnacle, it still asks if you're pregnant. And actually that's relevant as well, isn't it? Because it makes the immuniser stop and think. So I'm just thinking, what messages have you delivered to try and ensure that children are vaccinated?
So we produced Welsh leaflets for children. We also work with school nurses to provide information in schools, and we provided information to parents as well about vaccinating young people and what we know and what we don't, etc. Same for pregnancy. So on our WIS system, it says, is the patient pregnant? And when you say yes, it says, please provide them with this leaflet and this information. Please remember there is a GP on site that can answer any questions should they need it, etc., as a way of making sure that that person had a really good engagement.
And what about you, Carole? What have you guys been doing?
So we have been vaccinating the most vulnerable children. So we haven't been involved in the school programme, although that's going to change. So we have been talking about how vulnerable they are, like the young lad with who wanted to go on the bus. So talking about them and what is it that is stopping them doing what they want to do, and if it's a COVID vaccine, just explain to them, you know, the side effects and really why it's important for them to get it. And most of the vulnerable children have really taken it really well, and so it's having those conversations. And I think Lou said, you know, having Lou's using a GP, but we have advanced practitioners who do that. So they're the ones who are doing that for us. Mostly me, I have to say. As I said in my reflections, it's taken me a while to get some people on board to support me. But having those clinical and actually having, so I've got a general practice background, and I've been a nurse for 36 years, but also I've got a background with learning disability children. So I have that background. So it's easier for me to talk to the children and to reassure them, particularly with the learning disabilities. But having the learning disability nurse has been amazing as well. She's been along and having those conversations with us. And the school nurses, so I've had a few school nurses who have said, you know, can we do a clinic with you? Because they know their general practice and they want to bring the children in there. So a lot of the children have refused in Portsmouth, have refused to have it with the schools. So we're looking at, that's our next programme for the next 2 weeks, is to look at having joint clinics with the school nurses to get those conversations with us, their general practitioners, and with the safety of the school nurses.
And I think we should really raise that up, shouldn't we? The knowledge and expertise of a nurse who's immunised for, you know, most of their career. I worked in general practice as a practice nurse. I'm very early qualified, and the knowledge that you have and your adaptability and ability to communicate with people who have additional needs or who are elderly, you know, and actually you can swap between roles quite easily, can't you? Because that's part of the job. And I think we should lift up those nurses with those skills and recognise their abilities and thank them, you know, for everything that they're still doing.
Yeah, I completely agree, Heather. And I think the other thing that's made me reflect here is we've known about it for some time, but the number of people who are needle phobic and really, you know, quite frightened of needles. And of course, you know, mass vaccination of the population sort of brings that out. And the number of people I've had who sort of like quite sheepishly say, I'm really scared of needles. Not just people with learning disability, but people with learning disability particularly. And it's different strategies that you can use, and having the opportunity to have different people with you, you know, and obviously we have talked about this at the national level, and there are sort of some people who, you know, a reflection from one of my colleagues who tried really hard with one particular patient and just wasn't able to. Every time he took his sweatshirt off, he just sort of like climbed up and put it back on again. So, you know, and but I think you're right, it's those nursing skills that you're able to flip between different strategies for different groups and different people. And I think that you know, again, in reflection, there's possibly more that we need to do, particularly just needle phobic. It's interesting.
We made some changes with that.
Yeah, we did as well. The younger generation, I don't know about you, Lou, but our younger generation, so the 16 to 18 year olds, they came through when in the warmer months, and we had a lot of fainters, so we had to quickly change our way how we were doing it. And you know, the 3-minute vaccines went, you know, the time went up to 5-minute vaccines, so we could take the time with them, lie them down, talk to them, you know, and take the time with it. So I think we have to be adaptable in the clinics. I don't you know, we have to have and you have to have, you know, having the NHSP vaccinators have been good, they've been amazing, but you're right, it's our skills, because we've been doing it for such a long time, that we have to say, all right, okay, so we've got a few younger people now, so maybe we'll swap you to somebody else and you do something else. So we couldn't do that when we had St John's ambulance vaccinators, because all they could do was vaccinate. They couldn't observe and they couldn't do any admin. But with the NHSP, the Workforce Bureau, and this is one thing about being, you know, the conversations at NHS England, they have listened to us and they've provided us a workforce that can adapt. So they can go, so if you've got fainters, you can have more people in the tent, you know, and have the more senior vaccinating. So I don't know if you did that, Lou?
So we had, we used mostly our core staff that we either redeployed or additional hours. Plus then we had, we set up our own immunisation bank through the health board. So they were individuals. Some of them would be with the health board and some of them would be people who were retired or just wanted to do additional hours, but it didn't fall under their contract. We set up, each day you'd know the skill mix of your group, and you'd know who they were and who you needed to move around. If we had anybody that passed out, it was always a nurse that had to be with them. It couldn't be any other profession, because that's the unusual thing. You have this under the PGDs, you've got registrant, but of course that's not the protocol, not the same skills. So you have to be careful with the balance mix that you have on each day. We also, through some of our research projects, we vaccinated in things like leisure centres where we'd have big rooms and tables and that kind of be it. Was that people who were needle phobic were finding it very stressful to go into that big room and see everything and be expected to come through. And we also had feedback from our some of our other faith communities that they didn't really feel comfortable having to expose themselves in that kind of environment. So we used, in facilities where we had access to additional rooms, we created new entrances and egresses for people to come through, so they didn't have to come through the main hall. So they could come in, admin would make me aware there was somebody needle phobic at the front, a vaccinator would prepare everything, go up, collect that person, take them to a side room. They'd never come in and see all the hustle, bustle and chaos, and they would be vaccinated in those rooms. Others were fine to come into the room, they just really didn't want to be exposed. So we also had on the main floor, we set up privacy pods, which were just little pods where people could go in and have their vaccine in private, away from people.
That's good.
I think getting people to declare that is really important as well. So I still remember a very loud man who, you know, completely went green the minute we stuck a needle in him. So he was very loud and boisterous, and one of the other nurses vaccinating him, and you just it kicks in, doesn't it? You're there, and I was there helping this man before I even knew that I was there helping this man. And you're right about other people, because this nurse said to me, "Whoa, I learned so much from watching you." how did you talk him round? And I still don't know. It's just a skill,
Instinct,
isn't it?
yes,
An instinct. And I was there before she even knew that he had a problem. But yeah, I just think that's really interesting. Yeah,
I've been very privileged. I think one of the things that I've learned about myself is that I actually really enjoy being with people. So, you know, as a clinical director, you know, a lot of my work is strategic level work. And I think one of the great things about this program in particular, and running at an LVS rather than a mass vaccine site, is when people had fainted the first time around and had issues with their first vaccine, when they came around the second time, I'm saying, oh, would you mind? And they said, how did you know? But I remembered them. And that, you know, after 36 years in nursing, I know I look too young for that, don't I? But yeah, you know, you get to know your patients, you get to know them, and they were really glad that I, you know, not that I'd single them out because they were waiting in the queue or whatever, but that I'd actually remembered that they had a problem and that they appreciated that, so they didn't have to tell somebody, because we had lots of different volunteers. I don't know about you, Lou. We've had a great many volunteers, and we keep putting off a party. So in the summer, I was going to have a thank you party. Because I thought we were finishing it all in June. I thought it was all stopping. So we're going to have a thank you party for all the volunteers, all the staff and everything. And then we said, oh, we'll have a Christmas party. And now we said, oh, well, let's have a party in March because it's going on till March. So, but we've had
yeah. And I think, you know, one of the things that possibly hasn't come out, and one of my earlier reflections, I mean, I think we're sort of like, we're so much further down and we're still doing it. But it was the sort of sense of camaraderie, and we're able to do something. And I think because of 2020, you know, during 2020, you know, it was really managing the disease and all of that trauma and stress and everything else. And yet the vaccine program gave a sense of hope, not just for the patients. And I don't know about you, but, you know, the amount of presents and stuff that were, you know, people was just generally very grateful.
So grateful, yeah.
But also from the staff, you know, this sort of like really wanting to get involved. And I think, you know, you've both sort of said, you know, maybe that's a lesson to sort of think, you know, how do you spread this over? But certainly one of my reflections is it was quite a joyful experience, really.
One of the best presents
in on placements as well, and use the mass vaccination centres as actual clinical placements for our student nurses as well.
Yeah, we did that as well. Physicians associate students, I don't know if you've got those, but one of the best presents we got was some daffodils. So, you know, when spring started, so we had a florist came through and had a little episode. It wasn't anything, you know, and obviously we looked after them, cup of tea, as you do, not supposed to, but we did. But when I came back to the vaccine clinic the morning after, there was this massive bouquet of daffodils just about to open. And that was spring, and we were thinking, you know, this is it. We've just hit the daffodils are beautiful, aren't they? And that was so amazing from a patient. So, and we got, you know, I think we never realised that it was going to go on so long. I think that's the problem. And my biggest reflection is that you need to look after yourself and your staff. I think that's the biggest. So you know, everybody was willing at the beginning. We are so now our volunteers, I class them as staff now. The volunteers that we've got have remained with us all the way through, and they will be with us till March. So they're our staff, they're volunteers. They don't want anything. You know, I buy them a breakfast once a week on a Saturday, because it keeps them going when it's freezing. Through the summer we had ice creams, but they just keep coming back. We get paid for it, they don't, and they help us so much. And actually some of my colleagues have said, why can't we have volunteers in general practice? So I'm just looking at a research project in volunteers in general practice as well.
That'd be interesting.
In our day-to-day life. Brilliant. Because they've been brilliant and they want to help, and there's so many of them out there.
We used to have volunteers in Wales in general practice for flus. So they would come in and do coffee mornings, tea and cake and coffee mornings. This is obviously before my time, so I only joined last year, but they would tell me they'd have volunteers come in and do that, so that all the people that didn't get out that much and were quite lonely and isolated coming in for their flu vaccine, apparently they'd have a 3-minute slot for their flu vaccine, and they'd be in there for 2 hours, sat in the waiting room having cake and all sorts of stuff.
Oh, our waiting room's not
ask the chat, the room, because obviously this has been fascinating and lots of stories coming out here, which are all great. But has anybody in the chat got any questions, or I would say any reflections of their own that they might like to share. I know it's sometimes difficult for people in the chat. We would prefer you to have it on the chat, but if you really can't, then raise your hand, and I'm sure Sarah or Janan would be able to tell us, because the thing is, when you're presenting like this, you can't always see all the hands.
We've had one come up in the chat now. So I'm a registered mental health nurse, and we have extensive training with managing anxiety and administering injections. Did registered mental health nurses have any input in the rollout within your services, as I've not heard these nurses mentioned?
That's a very good question, but yes, I can certainly say, Sarah, that they registered mental health nurses and learning disability nurses were very involved, certainly at a national level, and the experiences I've seen at local level. But I'll let Lou, you were going to come in there.
Yeah, I was going to say, yeah, we had some of our clinical controllers were also mental health nurses who were really good at managing those kind of patients. We also had a learning disability lead who was very good at both those individuals would provide training not only to the clinical controllers but also to our vaccinators and our immuniser with tips and tricks and all sorts of different things about how they could help their patients stay calm, and also how to identify people. So when you're looking at a queue of people, what should you be looking out for of something that's a little bit, looks like somebody might need that bit of extra support. So they were instrumental to us making sure that people had a good experience.
We don't have many mental health practitioners in primary care. The ones we did help out, and Solent, who did the mass vaccine sites in Portsmouth, they utilised their mental health practitioners, as Lou said. But what helped, the people that helped us the most were the learning disability nurses, really, in general practice. And we have care coordinators with mental health backgrounds. So they're the ones that helped us with identifying those that needed that little bit extra care and attention, who probably, and anyone that we knew had care coordinators already. So those that were, with the bipolars and the patients who were suffering from severe anxieties, we put on special clinics for those so that they had more time, more space, more, so rather than on a Saturday morning between 9 and 12, we put on an evening clinic, between 4 and 8, so they have more time and space for them, so they can come with a care coordinator or come with a carer, so that they've got that little bit more, so they're not rushed. I mean, we're not really rushed in the clinics, but they are every 3 minutes. We have, the way we plan it is 3-minute vaccines. So somebody who's highly anxious, you have to make allowances for those, and so we did that, and we still do. Once a month we have we call it our extra clinic, just so that anyone in there can go who have extra time, really.
We've got another question in the chat, and this is I don't know if is it Rue Atchison, and practice nurse, and vaccinating since January, and saying that she had to have a chat with the practice manager to say that, well, she's very happy to vaccinate, you need to go back to other treatment room duties and you're feeling de-skilled. Does anybody else feel this? So this is something that's been raised, certainly from general practice. I would say it's quite varied, because you also get people saying, please use us to do the vaccination as practice nurses, a bit like Carole was saying right at the beginning. But I think that, that is something that, we've got to get the services, the other services, the wider services, the long-term conditions, the other treatments and opportunities for consultation that need to happen in general practice. But Heather, you might want to come in more there as well.
Yeah, I mean, I absolutely agree. I think some areas they've kind of been consumed by it. And I think the key issue for this nurse is that she's very new vaccinator, new into general practice. So I think they've kind of used her skills in an area, and actually they now need to start upskilling her again back into the profession that she chose. And it is a challenge, isn't it? Because it's getting the balance right, is in between making sure that we vaccinate as many people as we can, but also we continue with our other duties. And I think it's really important to note how much practice nurses and nurses working in that environment have continued to see patients, and I'm not always sure that that comes across. And actually, I know throughout this pandemic that nurses working in general practice have continued with their face-to-face as much as they need to keep their patients safe and to keep themselves safe, but they have continued to do that, and a big shout out to those people. But that is a good point that we need to think about. Actually, these nurses need to get back to the environment that they used to working in, and I think that's with a lot of deployed areas as well. Carole, were you going to say something?
Yeah, just that so now that the flu program's back on, so they'll be vaccinated for the flu program, but all of our nurses have still carried on doing their practice nurse stuff. So nothing has stopped. It's probably been a lot less because we've had to have cleaning in the times, but also some of them have worked at weekends for us. So whilst which is, you know, people get tired and you need to rest, but a lot of them do extra for us at the weekends. And that's why our clinics generally now are evenings and weekends, because business as usual, you know, we are trying to get back to that, trying to see more and more face to face. And as you say, the nurses have not stopped seeing patients.
I think the balance to that, though, is making sure we look after that workforce. They
definitely
are exhausted, aren't they? If they've been working 6-day weeks or 7-day weeks, there's only a certain length of time that can be kept up, isn't it?
And I think maybe that's where the practice managers might be saying, you know, just ease off and we share. That's why I use NHSP now, to give us that, you know, flexibility, so that we don't have to rely on the practice staff anymore, but they still come and do it, because it is a good, I don't know if the lady who's put it in there, it is a good program. You know, the people that come for vaccines are people that want to have the vaccines and they want to be safe, and you know, we do have good chats with them. I don't know about you, Lou, but we have lots of, you know, there's people coming out to vaccinate. Like I said, I talked to an 8 to 9-year-old today that was frightened to come out, and now she knows it's safe to come out. And actually, one of our volunteers is going to pick her up to bring her down. She doesn't want people to come to her house. So yeah, I think our teams, our practice teams, particularly our practice nurses, need to be congratulated to continue with their workload.
I think that was something I was going to talk about. Sorry, Lou, but Carole, that was one of the things I was going to talk about. I still remember the immense pressure of keeping patients safe when they came into that vaccination environment. So I remember the first time, one of the sessions I was in, there was way too many people in the building. And you're like, whoa. And actually, these people haven't been out, and they're just coming out. They haven't been out for months and months, just coming out to be vaccinated, and how we had to really, really quickly adapt the way we were doing things to make sure we were protecting those patients.
Yeah, and in the local vaccination centres, so in our surgery, the one that we use is a normal GP practice. We use the front end of it with patients at the back. So we had to have all the windows and doors open. So the vaccinators were freezing, and when you had to take people, you know, people had to take their clothes off, and so they were coming in and they had like 16 layers of clothes, and so we had to close the doors to make sure that they were warm. But then we had to open them again for the ventilation, because you couldn't. Well, you still can't really use the central heating or the air conditioning. So it probably wasn't the same, Lou, in the mass vaccine sites, but
exactly the same. We ended up giving out fleeces and gilets to staff to keep them warm while they were vaccinating. That was one of the things we did when we were first setting up, is measuring everything out. And of course, you have different setups for different populations. You can have a lovely big, what I used to call the cattle pen, where you could queue everybody up in a certain number of people inside. So they would come in, go through their COVID questions, get their leaflets, check in and be in the queue. But then you'd have to swap all that around if you had a group that was sort of over 80, because you didn't want them standing that long in the cattle pen. So you'd have to redesign that area to have a certain number of seats. And then you'd need a certain number of extra volunteers to make sure those seats were cleaned every time. And it was like musical chairs of individuals. And it's,
how many wipes did we go through cleaning those?
Good Lord.
Well, that's another issue, isn't it, in terms of sort of sustainability and
paying for PPE
all of the rubbish that we generate. There's a comment here from Anne-Marie Rafferty, so our past president, and she's first of all, she's put, thank you for all you've done, I'm so impressed with what's been achieved through nurse leadership, and here, Anne-Marie, I think, you know, we need to be shouting that from the rooftop. I agree with you, the collective wisdom of the work, as you've been sharing so brilliantly, for the future pandemics and learning. So I think that's certainly something to think. I mean, one of the things that I wondered, and obviously this is, you know, just to sort of capture some case studies, but that's, you know, a future thing, and it probably needs to be broader than the COVID program. Anne-Marie, I can see your cameras come on. Did you want to come back in?
Just to say, I've thoroughly enjoyed and learned loads from what's just been said. But I do think we need to find a way of all of the kind of behavioural, dare I say, insights that you've shared today about your experiences, but also the organisational tips and the workarounds and the incredible intelligence that you brought to this whole task. I just think is outstanding, and somehow we've got to bottle it in some shape or form. And you know,
we'll have to have some thoughts. Yeah. Sorry,
anyway,
Anne-Marie.
that was my only wee thought.
I think that's really important, because if you think about the last time there was a pandemic, and actually where was the learning from that? I know it was a long time ago, but actually, how do we capture that for the future? For future, you know, it won't be us that are managing, hopefully, God willing, it won't be us that are managing the next pandemic. So how do we make sure that this joint learning and all the things that have been achieved are transferred to the next person that has to manage a pandemic? That is a really...
Also said about how our vulnerable groups, we've had to go after our vulnerable groups because it impacts the rest of society.
Yes, yeah.
And in general, you've got to admit, nobody puts that much effort into finding our travelling community and making sure they're well, or our refugees, or our low socioeconomic groups. Nobody normally puts in that much effort. They just don't. We don't have the money, the resources, or the time. And I think what this has shown is the impact that work can do, but also some really good strategies to approach that. Mm-hmm. I think there's a lot of learning from COVID that shouldn't just be put aside for the next pandemic.
I agree.
I think that we can take it forward into a lot of our other services.
How have we been able to change so quickly? NHS Digital, they changed overnight. Being able to use video calls. Look at us, we're all using Teams. Video calls, video conferencing. You know, getting out and reaching these groups. So from what's happened with the COVID vaccines, we've actually managed to secure nearly £1 million to help develop a health inclusion cell in Portsmouth. So that's from going out and doing the COVID vaccines, from finding these people, you know, from going to the ports and working with the ports. So there is a lot of good work that's gone on. Yeah. And I think we should never forget that, you know, our practice nurses, my practice nurses have supported me in developing these programs. I couldn't have done it without my practice team. And they're the ones who are the ones that have taken all of the workload, a lot of the workload from me. And so the supervision that I used to do for them, you know, that's been, you know, that's gone from face to face. We do, you know, emails or Teams calls, but they've still managed to crack on. We've still managed to get PGDs done, but they've gone the extra mile, and they've worked with me to help develop some form of healthcare for the health inequalities. And so one of the things that I think we should do, one of our voices should be to get them the pay that they deserve. You know, if there's been money thrown at COVID, there's money, COVID, you know, the COVID oximetry at home, the COVID, you know, the BP at home now. So there's money being thrown at all sorts of projects, but the people that that have been the building blocks of this in primary care need to have proper pay and proper support. And I think if anything comes out of this,
and conditions.
If anything comes out of what we've done with our leadership, it's to give them a proper pay rise, because without them, we couldn't have done what we've done.
I think it's
interesting
evident
you
as
say
well.
that, because the Primary Care Academy's goal is to create these practice nurses that go on and be primary care nursing leaders. However, one of their biggest downfalls is that when they leave, they often end up going back to a health board or a trust or wherever it is they work, because the pay and terms and conditions are so broad. So you are putting these people through an amazing program who are then leaving primary care because they're saying, that's, you know, it's not,
Yeah.
those things are not working for me.
Can
So
we just see if there's any other questions? We've got another sort of 10 minutes on the clock, but I'm sure that on a cold winter's evening, people don't want to go overtime.
I think I'll say, just while that people are asking their very last questions, I think one of the things that we can learn as a you know, an NHS provider or working in health is that things can be changed quicker than we thought they were.
Absolutely.
Look at the things that have been changed, and you're right as well about the about things like doing things on Teams or doing things virtually. Actually, that takes away so much of the travel time. So if you're going to do supervision with someone, that, you know, it could take them out of a clinic for 3 or 4 hours to travel as well. And now we've got the resources, and we need to think a lot more about that, don't we? You know, how can we do things differently and expect to be able to move things on more quickly, because we know it can be done now.
And use the governance frameworks, particularly the governance frameworks that we've used for our assurances for our vaccine clinics. Those will help us to move things quickly as well, I think. Because we've got a national protocol. Helen, how long did it take us to get a PGD in a national protocol? Really?
Well, it didn't, but it did require change in legislation, didn't it?
Yeah.
So there is the consultation going on now to whether some of those changes to the legislation should continue for another year, whether they continue indefinitely. So, you know, that's all interesting stuff. And you know, I suspect there's arguments on both sides, but medicines legislation is one of the challenges. But as you say, you know, we were able to work through that, and you know, obviously the national protocol enabling. I suppose one of the challenges with the PGD is that it has to be the same person from start to finish. And of course, what the national protocol has given us is the opportunity to have people supporting the vaccine delivery as a whole, and admin to support some of that as well. So, you know, there's sort of, but I think, you know, from a safety and governance point of view, we mustn't forget that. So I think there's, for me, I think all of the things that you've mentioned, but I think it's bringing it in line with other programs which we mentioned before, and those lessons learned. So that's been a sort of frustration that I've raised as well, but certainly seen it on the ground. So I noticed that Sarah's been putting some various links and stuff, particularly the immunisation pages. We've got COVID vaccination FAQs on the website, so hopefully people will find those useful, and we will be keeping those up to date, and as the programme, as we've said, inevitably changes. I can't see any other questions. I'm going to go to you, Carole, first, and just, have you got any other things that you'd just like to reflect on? Just a minute just to sort of finish off, if you have got anything.
Just, I think we've done an amazing job, all of us in general practice, whether we've worked in the vaccine clinics or we've worked in general practice. Just thank you to everybody. And if anyone wants any help with any COVID vaccine questions for primary care, I'll pop my email in the address box.
You're getting applause, Carole.
Thank you, Carole. And Lou?
Yeah, just to really say, none of this could have happened without nurses. We often go unmentioned, and we did throughout a lot of the briefings where they would talk about vaccine updates, they would talk about GPs, but they wouldn't ever reflect who was actually coordinating and running these kind of services. So I think we didn't get a whole lot of the credit, but none of this would have happened the way it did without nursing. So I think our profession should be really proud of what it's achieved.
Yeah, here, completely agree. And Heather, have you got any other final comments?
No, I just it always makes me really proud to be a nurse when I sit on some of these, and reminds me why I came into this profession. So thank you very much.
Yeah, and I would completely agree. It is very humbling, but it also makes you feel very proud. So thank you. Well, thank you, Heather, but thank you to Lou and Carole. It's been great, really interesting. And finally, just a huge thank you to everybody for joining. We've had people, international delegates joining, which is amazing. And yeah, thank you very much.
And to our support team as well. We've been working along in the
Yes,
background,
sorry,
making sure
yeah,
that all this stuff comes together. So a huge thank you to the library services for all of their contributions as well.
Yes, seconded. If you don't know much about the RCN Library, look them up. They are fantastic.
They certainly are. Thanks for that, Lou. And thank you again. And good night.
Take care.
Thank you.
Bye.